My name is Sabrina Bajwah. I'm a clinical academic, so I work as a palliative care consultant at King's in South London, but I'm also an academic at the Cicely Saunders Institute. So I'm here today, excuse me, to present some of the work from COVPAL, which I think you've heard quite a lot of today. And specifically, I'm presenting the work related to ethnic minority groups, which we collected during this time. So the aim of what we tried to do within the COVPAL work was to map and develop insights into the response of specialist palliative care services for ethnic minority patients and carers during the COVID pandemic. And we did this through a cross-sectional survey, which you've already heard about today. And we gathered data which was both quantitative and qualitative in nature. So specifically, the questions within the survey, which I want to reflect on today, included, have you encountered patients or families with COVID-19 who are from Black and minority ethnic groups? Are there any differences in how you are supporting or reaching them? And are there any groups, different religions or cultures, where you have found supporting the individual needs of people affected by COVID-19 particularly challenging? So in the survey, we received responses from 277 UK palliative care services between April and July of last year. And I'd just like to say that we're extremely grateful for the fact that 168 of these services were UK hospices. So thank you very much for completing. So of the responding organisations, 34%, that's 93, had cared for patients and families from ethnic minority groups. So unsurprisingly, the greatest number of services supporting those from ethnic minority groups were in London, the South East, North and the North West and the Midlands. So, interestingly, only 23% of the responding inpatient hospice palliative care teams, 30% of the home palliative care teams had actually looked after ethnic minority patients during this time. And this is in direct comparison to 49% of the responding hospital palliative care teams. So services who had supported those from ethnic minority groups were significantly more likely to have had hospital palliative care teams and less likely to have had inpatient hospice or home palliative care teams. So from our qualitative work, a number of themes emerged. So whilst everyone suffered from not being able to see their loved ones at the end of life, respondents noted that during the pandemic, families of patients from ethnic minority groups were particularly affected by restrictions on visiting. These were blanket restrictions brought in on an emergency basis. So services reported that families struggled as they were unable to fulfill their religious and cultural responsibilities at the end of life. And Jamilla touched on this, and certainly within the Pakistani Muslim community, you have two Pakistanis here today, but it is normal that we would, in large groups, make decisions together and actually take an autonomous decision as a family together and really be available to provide physical support to somebody at the end of life is really paramount in our culture. So services reported that visiting restrictions appear to have a disproportionate adverse impact on ethnic minority groups. And these are a couple of quotes which I'll just let you read. So our data demonstrated that visiting restrictions may not only have removed patients' psychosocial support and advocates, but also their personal and professional translators. For many, their only means of communication. So I I am bilingual, and when I went to school at the age of 4, I couldn't speak any English, but luckily I can fully communicate now in English and be able to communicate my needs. But there are many ethnic minority groups that can't do that. And as we know, verbal communication at the end of life is essential to not only communicate what your needs are, but to actually have discussion about prognosis and really think about treatment and care. And for these patients, they had their face-to-face translators removed, and actually translators weren't available in hospital or hospices because of the infection risk. And for these patients, it was extremely difficult for then to communicate via telephone translators due to PPE. So similarly, policies introduced prohibiting physical contact with loved ones after death may have disproportionately impacted ethnic minority groups who are more likely to have contact after death with the washing of bodies and the prayer in large groups, which is often actually thought to help the person go to heaven as well. So services repeatedly stress the challenges in managing the distress for families related to these policies. So theme 4 was related to mistrust of services. So services reflected mistrust was present in some communities, embedded with cultural and religious values. And then there was also a suggestion that general mistrust of healthcare services, which services suggested was related to previous poor experience. So our theme 5 was a focus on equal and personalised care. What was incredibly interesting for me was that when services were asked if there were any difference in how they supported or reached ethnic minority groups, 66%, that's 61 of the 93 services that had looked after patients and families from ethnic minority groups, indicated that they hadn't adopted a different approach and all patients had been treated equally. So this view of equality seemed to be supported by the perception the assessment of patients' needs was personalised and that any care subsequently delivered to them was therefore appropriately matched to their needs. So I just want to really highlight the positive examples that were noted in the qualitative data of services reaching out to external faith groups to support patients to reduce the impact on ethnic minority groups. So some services explicitly stated they were well versed in serving a diverse population and already had established links with their local ethnic minority groups. So for some services, there appeared to be little consideration about issues that didn't go well. And for example, if the challenges associated with poor communication were considered, the responsibility to resolve this was placed with the patient and their family and not with the service. And there was a lack of self-reflection on how services themselves could improve. So our findings from this work, and this is a table from the publication in BMJ, Supportive and Palliative Care, and it really suggests that at the moment within palliative care we have a perception that we're delivering equal and equitable care to ethnic minority groups, and we have a bar of high quality palliative care and outcomes for these patients. But actually the reality is is that we're unable to deliver that bar of high quality palliative care and outcomes because we can't respond to cultural and religious needs. And part of that is the impact of policies which are brought into place. So in our paper, we really consider what we need to do to address these needs and reach that high bar of palliative care outcomes. And I'm keen today, really, not for us to sit here and talk about how bad the problem is, but actually give you ways in which you can improve the situation. So, of course, we've all for many, many years, had the focus of palliative care delivery with personalised care at the heart of it. And I think that is incredibly important that we continue to do that. But in addition, we need to think about how our policies impact those groups, and we really need to consider that. And one of the ways that we can do that is by actually conducting equality impact assessments of any policies that we have in place or before we change policies. And it's really important that those people who conduct those equality impact assessments are of a diverse group of people, because otherwise you will get a very blinkered assessment. It's really important that those groups that you are trying to improve outcomes for are included in actually developing your service. And we need to think about how we're distributing the resources within our hospices and palliative care services. And fundamental to that is actually data. Data is incredibly powerful. We don't know that we are delivering equitable care until we go and look for it. So for the first step would really be to make sure that you are defining ethnicity appropriately for each of your patients. So ethnicity is a self-identified characteristic. So you need to ask your patients how they identify from an ethnicity perspective, and then actually collect data around outcomes for those patients as well as your overall population to see whether there is equality and equity in the service that you deliver. And we need to deliver culturally congruent care. So for me, I have a big passion around the language that we use. So language is incredibly powerful. So we've used ethnic minority, the phrase ethnic minority, throughout this paper, and that's because it was recommended at the time. But even that language, calling a group a minority is in itself a microaggression, because you are the majority. So it makes me reflect on all the language that we use, that the hard to reach, the difficult families, and you know, they're not really difficult families. Actually, they're families with a different belief system. So I think really reflecting on the language that we use is a journey that we all need to make. And importantly, I think we have all grown up in a society and live in a society where the white British way of dying is the dominant way of dying, and almost the way of dying that everybody is stamped with. And actually, for us from ethnic minority groups, it's not necessarily the best way to die or the way we want to die. So it's important that we start to think about centering at the margins, so really thinking about what the people who aren't in the dominant culture may want. So the last 18 months has completely changed me. So I've worked in palliative care I've been a palliative care doctor for probably 18 years and a consultant for 12 years. And I think that the last year, working at King's, we were hit really full on by COVID, and we had over 400 patients referred to us in our palliative care service in the first wave, and we are really lucky to have a 50% ethnically diverse local population, and it's an extremely deprived socioeconomic population. And actually seeing those patients die in the way that they did, and seeing the inequality in the service that they perhaps received, and actually seeing how these patients weren't able to communicate with their loved ones in the same way, or losing their translators and having impact of policy has really opened my eyes. And for me, I think that you see, seeing as well the impact on personally and on the community that I live in has really changed my outlook forever, really, around racial inequality. I think we've all got an opportunity, really, to change what we do and how we practice, and I know that I will be changing everything that I do going forward. Once your eyes are open to racial inequality, you never stop seeing it. You see it everywhere. And I think we would like to ask you to all be allies and advocates in this cause. Thank you.
A few years ago, my colleague Catherine Sleeman gave a great TED talk at Royal Albert Hall, where she spoke about the incredible progress that had taken place in medicine over countless decades. But despite that, mortality reigned firmly fixed at 100%. We know that is an immutable fact. We know that death doesn't discriminate, but it does when we start focusing down on minoritized communities, people who live in materially deprived areas, and intersectionality therein. Over the last 20 years, I've done a great deal of work that's focused largely on disadvantaged dying and the experience and the outcomes of care for people and their families from Black, Asian, and ethnically diverse communities in relation to location of death, in relation to the interface between symptom attributions and religion and faith, focusing on newer illnesses amongst certain ethnic communities, for example, multiple sclerosis. Taken as a whole, and then when we start to think about material deprivation, and then the litany of reports that precede my work, for example, the Black Report from 1984, the Health Divide, and the Atchison Report, which also focused on inequality and inequity when it comes to health and illness and ethnicity. They paint a really bleak and sobering picture. What happens in this room today should change lives. In palliative care, we talk a lot about location of death. Where people die is really important. We focus on where people want to die and how can we make that possible. And a good number of surveys, and I'm going to take my hat off to people like Barbara Gomez, who's done a great deal of work in this area, that's looked at preferences across a variety of European centres, where predominantly, given the hypothetical scenario, people said they wanted to die at home, followed very closely by hospice, and the least preferred locations were institutional settings like hospitals or care homes. And this is a really powerful statement. A really powerful mission statement way back when Cicely was contriving and devising what St. Christopher's would represent. In hospice care, there will be no barriers to race, colour, or creed. And these were really laudable aspirations. But the reality has been very different. Shame on us. So, I'm going to focus on just a few hotspots. This was a piece of work I did several years ago where I analysed close to 95,000 cancer deaths over a 10-year period in London. And I wanted to understand the relationship between ethnicity and location of death. And very regrettably, death registration certificates, you may or may not know this, don't record ethnicity. They only record country of birth or country of origin, which meant that we had to focus on first-generation migrants, and which meant that second-generation and first-generation migrants were completely invisible. So that said, what did we discover? We discovered that people from Black, Asian, and ethnically diverse communities did not die at home as often as their white peers, after taking into account all other factors. And when we think about hospice, which is the bread and butter of the work that you do, as well as servicing the care of people in the community, we discovered that when we looked at deaths in hospice compared to all other locations, using white British people as the marker, people from certain ethnic groups were palpably less likely to die in a location that provides an exclusive service to a social elite. So at the time, I hypothesized what the reasons for this might be, and I did work that focused on awareness of dying or awareness of palliative care services in relation to demographic factors, and I focused down on people's postcodes, which gave us a metric for how rich or poor they were, how much money physically they had in their pockets. And what we discovered was that people who lived in materially deprived areas, areas which were largely populated by Black, Asian, and ethnically diverse communities, were on average 8 times less likely to understand what hospice was, what palliative care was, what Macmillan nurses were. And I said, that's the problem, they just don't know. But I have revisited that notion over the last period, because that places a burden of responsibility on those individuals to come forward to be aware of the brilliant care that you offer, rather than us actually saying, how can we engage with certain communities in a much more creative way and get them on board and share with them and open up our doors to tell them what we're doing and bring them in to share the currency of that superb care. The other hotspot is pain. Now this again, I'm not going to teach you how to suck eggs. We know that pain is a very prevalent symptom in advanced disease, and specifically in cancer. We know that the prevalence of cancer pain goes up to in excess of 90% in the most advanced stages of the disease. We know it compromises what we might refer to as a good death. We know that poorly managed pain is a frequent reason for crisis care or out-of-hours care with GPs, or a reason to want to go to emergency departments in the middle of the night because that pain is poorly managed. And when we start thinking about how pain is managed, we know that there are some really simple solutions out there, pharmacological agents like opioids or morphine, which is a quality marker for managing pain. And when we start to understand the interface between ethnicity and pain, we have to go across the pond to really explore some very rich data, some beautifully and articulated studies that have examined this in great detail. And what we discover from those studies is that people who are African American and non-white Hispanic are more likely than not, after taking all other factors into account, to get subtherapeutic doses of morphine to manage their pain. Period. What do we know of the situation in the UK? Very, very little indeed. We know from the National Cancer Patient Survey that people from Black, Asian, and ethnically diverse communities are less satisfied with the management of their pain than their white peers. But beyond that, no one has ever done any work to quantify material differences that make a difference to cancer pain at the end of life. I did a case note audit at a hospice very close to where I work. I had 40 Afro-Caribbean and 40 Black Caribbean and 40 white British patients. And what we discovered was that the equivalent daily dose of oral morphine was nearly half as much less for those individuals from those two ethnic minority communities compared to their white peers. And here's a quote from a PPI person I've engaged in a study that I'm running with Sabrina in the new year. So the reasons for this are complex. They are patient-based or person-based in relation to symptom attributions, potentially poor relationships historically with healthcare professionals where they haven't felt empowered to talk about their pain, and also health professionals, particularly where the individual states that their pain is very severe and they do not share the same ethnic identity as the person who is assessing their pain, and their pain is not taken seriously. And then above and beyond that, the conscious and unconscious biases of the professionals who are caring for them. So, at last, and I'm so grateful for this, NIHR are taking this issue really seriously, and they funded a study which will take place in the new year, which will examine for the first time in the United Kingdom the relationship between ethnicity and opioid prescribing in the last 3 months of life in relation to health service use. And this is a study that I'm running with Sabrina. Let's move on to another hotspot, and I'm going to bring you right up to speed with the pandemic. And we know the pandemic put health systems under considerable stress. There was not so much as a micromillimeter of elasticity in terms of what services could do. And as a consequence of that, the great and the good came up with very important guidance on which patients to escalate to ICU and which patients to potentially de-escalate in terms of triaging and reverse triage. NICE put together the rapid guidance for critical care. And something that they emphasized at the time was that they needed to focus on the likelihood that a person will recover to an outcome that's acceptable to them, and that wherever possible, healthcare professionals should ask that individual what their values and preferences are, or to ask their family members. If we go back to the States, some very elegant algorithms were constructed that focused on which were the best candidates who might benefit from ICU treatment and escalation and ventilators. And they focused on morbidity and mortality, and they focused on the number of different conditions that individuals had, and whether patients had previously had issues with their kidneys. And what they discovered was, after they went back and looked at the data, was that the lion's share of those individuals who were denied ICU care were living in areas, geographical areas, that were populated by minoritized communities. So the issue is, if they weren't getting care in ICU, what was their experience about? So we come back to the United Kingdom, and this is where I hand over to my colleague Sabrina to tell you the story in the UK.
I'm a bit short, so I don't like standing behind lanterns. So, good evening, everyone. We want to thank Hospice UK for doing a plenary on this topic. And unusually for a plenary session, we're going to have 3 presenters. And we're all going to do a short individual presentation, but then we wanted to give plenty of time to kind of start this conversation about how we go forward with this issue. So for me, this conference comes at a time when I'm really reflecting on the role I've played in trying to address this issue in the past and what I could and should be doing in the future. And I wanted to just share some of those more personal reflections. So I think it's important to start with understanding why we've chosen to have 3 of us here today rather than one of us. And I think a lot of that is to do with us all finding it increasingly difficult to discuss this topic, especially with predominantly white British audiences. And I think over time, I'm recognizing more that this topic for me does trigger deep-seated feelings, so feelings of being inadequate, perhaps not fitting in just as much, not really belonging. I think I feel exposed because I've spent a lot of my career trying to get people to look past my race and background, and through raising my head above the parapet with this topic, people start seeing me through that lens, and that has always only brought disadvantage for me and people that I know. And also, I think over the last year and a half, I've spent a lot of time talking to people within palliative and end-of-life care around this topic. And I guess more so now than a year and a half ago, I have an insight in the underlying subtle resistance to make the level of change that's required to actually have genuinely equitable care. I've been told, that racism isn't one of the issues that results in inequality in access to our services, that we are shoehorning racism into issues where it doesn't belong. So discussing this stuff is hard. We also wanted to kind of demonstrate that we see that there's a small but growing and hopefully a critical mass of individuals and organisations who really do want to tackle this issue, and in an uncompromising way, in a way where we really fight for equity and nothing less than that. But also that there's a diversity of opinion within this space. So even for the three of us, we have different thoughts on what the real priorities are, how we might focus our energies to address this issue. And we need to create space for that diversity of opinion. And we also want to recognise that all three of us have been privileged over the last year to be given platforms such as this to talk about this issue. But there still remains important voices that remain silenced, that haven't been amplified, that haven't been given that space. And we need to continue to listen out for those voices that we're still not hearing and provide them with that opportunity. In terms of reflecting on how my thoughts and feelings have evolved over the last year and a half, when I look back at George Floyd's death, that was a real turning point for me. And when I think about it, I remember and probably recognise more so now just how angry I was. I was so angry. I was angry at society. And I was also angry at local and national leadership in palliative and end-of-life care, in the fact that there was such a big silence on how race and racism plays its part within our specialty. We thought that perhaps we were exceptional in that case. I also felt very sad for a long time for George Floyd and his family, having been someone who's experienced racism and having a family that's experienced it. I know that powerlessness, but also I felt guilty because I've never felt racism on that level. Being Pakistani rather than black makes me privileged. And also, I guess it also triggered a lot of anxiety because all of this happened within the context of COVID-19, where almost on a weekly basis around that time, I knew people who were getting COVID, people within my community who were dying in large numbers, when perhaps my colleagues and my friends who were white, British and more affluent didn't have that experience. Importantly also, though, it made me reflect on my role in perhaps enabling and perpetuating racial prejudice and discrimination. At an individual level, it made me think about how I have internal racism against people from my own community, in that I never thought that they should and could potentially have just as good an end-of-life care experience as white, British, middle-class patients that I was seeing, and I didn't fight for them to have that. And that manifests itself in my experiences as someone with family members dying in a hospital situation, and feeling when we were asking, can more family members visit, can important members of the community visit, because this is so important and fundamental to our culture, rather than seeing that as a strength of my culture, I was ashamed and I was embarrassed that when someone died and people from my family and my community, especially women, mourned loudly, collectively, together, rather than seeing that actually that's a strength of our culture, that we do recognise that grief and bereavement is important and we do it collectively, we publicise it, we do it together. I again felt ashamed. I've always felt ashamed in those situations. And that's because I know NHS culture. I know the culture that we work within would see that as foreign, as disruptive, and probably also undignified. And even when I've accompanied family members who can't speak English, who have poor literacy, when I've accompanied them to NHS clinic appointments, again, I've apologised and said, I'm so sorry, because I know that that is going to take extra time and resource within that limited time that that clinician has, instead of fighting for the fact that actually these people deserve to be provided with information at a level that they can understand so they autonomously can engage in shared decision making. So I really had to reflect on my individual part in enabling racial prejudice and discrimination to exist. At an interpersonal level, you know, this is the kind of racism we more commonly recognise, that between individuals and groups. So more than once I've had patients say that they didn't want me as their doctor because I wasn't white British. And again, rather than saying that that is wrong and escalating it and making sure that those who are coming up behind me didn't face the same thing, I wanted to push it under the carpet. I didn't want people to see me through that light. I didn't want to create a fuss. I just wanted to be part of the team. And that actually wasn't the best response. And also, you know, when a palliative care nurse said that she didn't think it was her role as a nurse, but also the role of the hospice to support a Muslim patient to pray in their last days of life, that even though I escalated that to their line manager, I didn't see it through to see what was actually done to ensure that any patients that were supported by that page weren't discriminated. Again, I didn't follow that through. And that, again, was my failing. And probably one of the most enlightening things as I've thought about this issue about racism is my understanding that racism is it's a system level issue. We all as individuals, even those of us from minority groups, have the capacity to have racial prejudice, i.e. think that we're better than someone else based on race and ethnicity. We can discriminate against them on that basis. But for racism, that's about individuals and groups who have power over other individuals or groups and use that power systematically to disadvantage those groups. So if we are going to tackle racism, we need to focus on where the power lies to enable that to happen and to redistribute that. And to me, we can accept nothing less than equal representation at the decision-making table, at the most senior level. But again, when I reflect on my experiences over the last year and a half, I've been invited to lots of committees, think tanks, presentations such as this. And I've always seen that as a positive thing, that people really want to diversify the voices that they're hearing. But if in those situations you do not create an environment that is inclusive, and what I mean by inclusive is that I can bring my whole self, that I do not need to assimilate to the dominant culture within those groups or the power structure, then actually you're not doing me any favours, you're not listening. Furthermore, if in those spaces there is not equity, and what I mean by that is constant and consistent assessment of where the power lies and redistributing that, again, you are inviting me to share something that is really important to me. It's an issue of life or death for those of us from minority groups, but we're not given any power to enact any of that change, and that is actually more damaging. The final thing I wanted to kind of share was the thing that I've been reflecting most on recently, which is what does anti-racism actually look like? So I think there is a need for that individual self-reflection on the role we as individuals may play. It's that recognition of when interpersonal racism occurs and making sure that we are allies and identify that and do not allow it to occur. And it's ensuring that those power differentials are redistributed. But the thing I keep coming back to is the need for kindness and compassion in this space. That we need to be kind and compassionate to people who want to be allies in this space, who really want to make a difference but don't know how to. And they're so afraid of saying or doing the wrong thing, they feel paralysed. We need to create spaces where people can make mistakes and still be seen as doing the right thing and at least trying. I think we also need to be kind and compassionate for people who perceive or potentially will be disadvantaged by any affirmative actions we take to try and create more equitable services, especially because we know resources will always be limited. And we need to be kind and listen to those voices too. And probably the thing that I've come to very late is the need for kindness and compassion and acceptance for those of us from minority groups that actually we have a limited role we can play in this space. We don't have the power. And that makes me think of this quote by Toni Morrison, which states, I can't read that because my glasses aren't very good. So it states, the function, the very serious function of racism is distraction. It keeps you from doing your work. It keeps you explaining over and over again your reason for being. Somebody says you have no language, so you spend 20 years proving that you do. Somebody says your head isn't shaped properly, so you have scientists working on the fact it is. Somebody says you have no art, so you dredge that up. None of this is necessary. There will always be one more thing. And that makes me reflect that maybe all this anti-racism work that we're spending so much time and energy away from our family and loved ones trying to enact change, maybe it's just a distraction, maybe it's a function of racism. That perhaps this is our Sisyphean task, that we just have to roll this boulder up the hill only for it to roll down again, and then we're compelled to roll it up again, and somehow we've got to find some meaning within that. That maybe in 10, 20, 30 years we'll be presenting the same stories and the same data and nothing will have changed. And if we look at history, that's probably more likely than not. But in my heart, and it is my heart that I'm having to rely on now, I genuinely believe, through discussions I've had with people who are here today in this audience, that in the majority, in palliative and end-of-life care services in the UK, people do want to tackle this injustice. That we recognise that the roots of palliative care in the UK come from wanting to tackle injustice. So I think there is buy-in into the why, and now we need to focus on the how. And I think the basis of that has to be having open, inclusive, safe spaces for everyone to be heard, including those who most disagree with us. Thank you. I'll let Jonathan come.